Okay. Hi, everyone. There's a few participants just trickling in little by little. I see some names that we recognize, some we don't. Great to have you here. I'll start the webinar now, 12 on the dot, just so we can get going with our week 3 of our Spotlight series on health economics. Thanks, everyone, for joining us. It's great to have you. So if I can click there. Before we start the webinar, I just would like to acknowledge the Ghana people as the traditional custodians of the Adelaide region. We recognize the Ghana people's cultural, spiritual, physical, and emotional connection with their land. We honor and pay our respects to Ghana elders, both past and present, and all generations of Ghana people now and into the future. Now, I'm not sure where everyone is joining us from today. Usually we have mostly people from here from Ghana land, but if you're joining us from other regions, it'd be great if you tell us where you're joining from in the chat and say hello to the webinar attendees. So what is the Spotlight series? This is something I present every week. So I just reiterate what this initiative is. It's a health translation essay capacity building initiative, and we hold it every quarter. So it happens 3 to 4 times a year, and we shed the light on a topic of research translation. This month, we're looking at health economics. So for the whole month, we are hosting weekly webinars. We share upcoming training opportunities. We share online resources through our social media channels. So if you don't follow us already on Twitter and LinkedIn, I highly encourage you to follow HTSA to get all our latest news and updates, specifically for the Spotlight series this month. And we share interesting publications on the chosen topic. So this month, we are looking at health economics. Previously, we've looked at implementation science, consumer engagement. We've explored the MRFF, how to maximize your chances of getting grants. And our next Spotlight series is going to be on PREMS, so patient-reported measures, and that's going to be in June. So it'd be great to have some of you attend again. Who's Health Translation SA? Well, our purpose is to accelerate the translation of research findings into healthcare practice and policy, and to increase whole of system research translation capacity to improve the health of all South Australians. What that means is that we act as independent catalysts and brokers. We mobilize collaborations between researchers, policymakers, key stakeholders, education, the community, and consumers who have lived experience, as well as health services. We bridge all of those gaps. We bring people together to ensure that the research that's being produced here in South Australia actually gets translated, actually gets applied into policy and practice. And so our whole philosophy is that research translation is a mindset. It starts from the beginning of a project. It's not something where you do a research project and at the end you're like, oh, I'd like to implement this. It's really having a think about who your next user is. Who's the end user of your research? Are they involved in your project? Do they have a say in how you're designing this project? And what's the ultimate problem you're trying to address? So it's ensuring that all of the pieces of the puzzle are there throughout your project, from the start, through the activities, outputs, and then ensuring that your project can be scaled and sustained. Today, we're looking at health economics in aged care. So we have 3 speakers who will share with us examples of economic, evaluations that have been done in this area. We have Jyoti Khadka from Flinders University. He also works at ROSA, which is the Register of Senior Australians here at SAMRI. We have Dr. Rachel Milte from Flinders University and Associate Professor Billingsley Kaambwa from Flinders University as well. Now, I will first hand the mic over to Jyoti. Before I do so, I'd just like to introduce him a bit more formally. Dr. Khadka is an optometrist by training. He's worked in the Flinders optometry space for 7 years as an academic researcher before moving on to healthy aging, health economics, health services, and aged care research. His PhD is from Cardiff in the UK, and that was followed by a postdoctoral fellowship at Flinders. So he's been here for a little while. And so his main areas of interest are around healthy aging, patient-reported outcomes, frailty, quality of life, and the application of modern psychometric methods. So I will stop sharing my screen and I will hand over the microphone and screen to Jyoti. And you have 15 minutes and I will try to flag if we reach time. Thanks, Jyoti.
Thank you, Agustina, for the introduction. So basically, we are actually doing a kind of this presentation in tandem where health economics, but about a tool we have developed, which is applicable for health economics evaluation in aged care. My colleague, Rachel Milte, will talk after me, will be talking specific about health economics in aged care. And then that will be followed by Billy's presentation, which is also aged care specific health economic evaluation. Let me share my slide here. So the topic of my presentation today is quality of life instrument for quality assessment and economic evaluation in aged care. This is just the outline of the presentation. So what I'm going to do is to start with some issues and challenges associated with aging and aged care, and then talk about aged care and older person specific quality of life instrument we have developed at Flinders University, which we call QALAC, Quality of Life Aged Care Consumers. I'll be talking about development, validation, and valuation of this instrument and how this instrument can be used in economic evaluation. Just briefly about some statistics about aging. Like many OECD countries, Australian population is aging rapidly due to increasing life expectancy and declining fertility. The figure on the right-hand side of this slide shows there has been a continuous growth of aged population in Australia from back in time, from 1935 to into the future. So currently, 1/7 of us are 65 years and older. And that accounts for 16% of total population is 65 years and older in Australia in 2020. But it's projected to be going to be almost 1/4 of the total population in 2066. When you talk about very older people, like 85 years and older, we have got more than 2% of total population is 85 years and older. Just 2 years ago, it's increasing, and in the future, in 2066, it's going to be almost 5%. I just want to share another interesting statistics that actually shows the ratio between the working age population versus older people in Australia. Roughly 50 years ago, there were more than 100 working age people for every older person. Few years ago, that is in 2018, there has been significant decrease, like just about 30 people working as people for every older person. And in the future, it's going to be alarmingly low. This is a significant challenge for developing countries. Something has to be done at the policy level to address this massive workforce issue. So what are the challenges with aging is that people who are aged, they use significantly high amount of health and aged care services. I just want to throw some statistics here. Among older people, 65 years and older, more than 40% of all hospitalization, almost 50% of all days spent in hospital, and significantly high use of ambulance services are attributed to older people. Currently, Australian government spend like $106 billion to basically run these healthcare services. So when you actually look at the utilization of these healthcare services, significant amount is basically utilized by the older population. So when you talk about aged care, So among 65% older Australians, 10% of the total population of 65% older are using some form of aged care services. And that accounts for 1.5 million aged care services per annum. And this has costed almost $24 billion to the government last year. And it projected to significantly blow out in the future. In 2055, it's projected to be around 80 billion per annum. So we are very fortunate in Australia that we have got aged care system for those who need aged care and who have got care needs, and that's also government subsidized. But aged care in Australia was placed in a global spotlight due to the Royal Commission into Aged Care Quality and Safety investigation, which ran for 3 years. The investigation found many systemic failures, the reports of abuse, and neglect, and concluded that the current system delivers services that are too often substandard and unsafe for our older people. The Royal Commission produced a final report in 2021, February. In the gist, the conclusion of that report was that the quality and safety of aged care cannot be improved without measuring and reporting upon key quality indicators. So the Royal Commission produced around 148 odd recommendations to fundamentally reform aged care. So one of the recommendations was recommendation number 22, which basically says that there should be implementation of comprehensive quality of life assessment tools sector-wide, besides traditional clinical indicators of care quality, such as pressure injury, fall, sedative loads, and others. So when you talk about quality assessment in aged care in Australia, it is very necessary because it is critical for public accountability and transparency. And also when there is a ongoing quality assessment and it is on the public domain, there is a kind of a push for improvement at the facility level as well and the sector-wise as well. Given that aged care system is more actually focused on providing better services in a just and also quality of life. So the quality assessment in aged care should include person-centered indicators. For example, quality of life experience, that is PREM measure, or quality of life instrument alongside traditional clinical indicators. When you talk about economic evaluations in aged care, so when you did a systematic review, we found there's a really economic evaluation are really conducted in Australian aged care sector. But we know that economic evaluation provides really good evidence to facilitate effective and efficient distribution of limited resources. And also provide the evidence about balancing the cost and the benefits. Given that aged care system or any system per se we talk about is actually the end product is providing the better quality of life. So benefits for the economic evaluation should be assessed using quality of life and also from the older person's perspectives. So what are the issues and opportunities here in measuring quality of life? As I mentioned earlier, there's a lack of economic evaluation in the aged care sector. There's several reasons. One of the main reasons is the vacuity of suitable preference-based quality of life instrument for quality assessment and economic evaluation in aged care. There are a few studies, they have used economic evaluation, but the outcome measure of quality of life they used was instruments developed with older population for all ages, and most of them are not aged care specific, but more healthcare specific or social care specific. So the existing instruments that have been used may not reflect the domains that are much more important to older people or use appropriate languages that reflects their experiences. So the project we undertook to develop these tools was basically saw this opportunity and also the gap. And we try to address this gap by developing a suite of person-centered quality of life indicators. Basically, there are two tools we have developed. One is POLAC, that is expanded form is quality of life aged care consumer, which is a quality of life instrument, and the QCE-ACC, which is quality of care experience aged care consumers. Recently, both the tools are incorporated into the National Aged Care Mandatory Quality Indicator Program, and this is a landmark kind of, I would say, the policy win for us, and also for the people who are using aged care services. And the data collection will start from next month. Given the time limit is just 15 minutes for this presentation, I'm going to talk about just QALAC, not the QCE. So the development of QALAC and the validation of QALAC was a 4-year journey between 2018 and 22. The project that actually we undertook was funded by the ARC Linkage Grant, and there were almost 1,500 aged care consumers participated in this project, and from 5 Australian states. And also we have got a series of industry partners who also took part in this study. And the work was undertaken in 3 phases. The phases were phase 1, 2, and 3. So phase 1 was comprehensive literature reviews, in-depth semi-structured interviews with older people in home and residential aged care settings, a comprehensive qualitative data analysis to develop and test draft items for the descriptive system of the QALAC. Phase 2 was psychometric testing to assess feasibility, feasibility, practicality, and also finalize the item selection for the final descriptive system. Phase 3 was the further testing of the validity, reliability of the final descriptive system, and also the valuation study to develop final preference-weighted scoring algorithm, which can be used for economic evaluation. So I'm going to talk about phase 3 of this study in this presentation. So this slide shows the QALAC final descriptive system. It has got 6 dimensions, which were basically determined by the older people who took part in phase 1, saying that these are the most important and critical domains of quality of life, which are SK specific and older person specific. So each dimension is represented by a single item, and each item or each dimension is rated on a 5-point frequency scale from none of the time to all of the time. And these dimensions are independence, mobility, emotional well-being, social connections, activities, and pain management. This slide basically shows the constructability assessment of the QALAC, where we assess the relationship between QALAC and other instruments. So constructability is defined as the assessment of whether the tool or the instrument measure the construct is supposed to measure. For QALAC, it's HK-specific quality of life construct. So what we did was we did 2 separate studies, one in residential aged care setting and the other in home care setting. And we actually administered QALAC in other instruments, and then later on we did a correlation. So what we found that there is a kind of a moderate relationship between QALAC and other instruments, which basically indicating the construct validity of QALAC, because if it is just moderate, that's why QALAC actually provides a unique and distinctly different construct than the existing other instruments like ASCOT, which is social care specific instrument, EKIFIED, which is healthcare specific instrument. So this figure shows the known group validity. Known group validity is assessment of whether our tool QALAC can discriminate between those people who are known to be different. So this is the home care data. So we have actually did the known group validity for self-reported quality of life and self-reported health status. The figure on the left-hand side of the slide is the self-reported health quality of life, which has got 5 categories from excellent to poor. And y-axis is the QALAC score, and you can clearly see that the higher the score of the QALAC, the better is the quality of life. So you can clearly see that people with the higher quality of rating had higher quality of life score, and they are significantly different between each category. And same was the case for health status as well. People with higher level of health ratings have higher quality of life score on the QALAC. So QALAC can discriminate between people known to be different. So this is basically informing known group validity of the instrument. And what we have found is the relationship between the QALAC and the quality of life stronger than health. It's because that health is a completely different construct to the quality of life, and everything that happens in quality of life can't be explained by health, and vice versa. So this is the known group validity in the residential settings, and we found similar kind of known group validity for self-reported quality of life and self-reported health status. We also did the reliability assessment of the QALAC by administering this QALAC um, 2 times within 2 weeks interval, just to see how reliable is the instrument. And at the bottom of this table, I have actually highlighted the intra-class correlation coefficient, this statistics, which is 0.85, which is an excellent reliability statistics for the QALAC. So basically signifying that the QALAC is a reliable instrument if you want to use this for a repeated measure for a longitudinal study. So coming to the methods of data collection for QALAC, so we have actually developed 3 versions of the QALAC. One is the self-complete for those without or with mild cognitive impairment. Also interviewer-administered version for those who can complete with some assistance, like those people who have got vision problem or can't read or write. And also we have the proxy version for those with moderate to severe cognitive impairment who cannot provide this kind of survey data reliably. So we have actually given a specific recommendation for choosing a proxy if a self-report is not possible. The proxy should be someone who knows the person well and sees them regularly. And we recommended that only a care worker is given a chance to give a response on behalf of a respondent of a user if only other proxies are not available. Coming to the scoring of the QALAC, so QALAC can be scored 2 ways. One is the summary score, other is the preference weighted scores. For summary score, QALAC uses 5-point scale from none of the time to all of the time for all 6 dimensions. So scores for these 6 dimensions added to give a total score which ranges from 0 to 24. Highest score is better quality of life. And the table on the right-hand side basically shows the cutoff for poor to excellent quality of life, and we have created 5 cutoffs. And this is basically based on the distribution of the summative scoring. And also based on an expert panel acumen about the distribution, looking at the distribution of the summative score. Given that summative score are basically based on equal weight given to all the dimensions, which is basically not a kind of ideal situation. That score is not basically kind of valid for economic evaluation. That's why we also develop preference weighted score, which can be used for economic evaluation for QALAC. Regarding preference weighted score, so how we actually developed a preference weighted score was that we actually used a discrete choice experiment approach with survival duration. There are other approaches as well. However, DCTTO is kind of a hot cake and widely accepted kind of methodology in health economics to develop a kind of valuation sets for new instruments. So DCTTO approach is based on random utility theory. When presented with a set of options, in this case, quality of life, states of varying survival duration. So we ask individuals to choose the option that generate the highest amount of utility. This approach has been utilized to generate value sets for other preference-based instruments as well, for example, EQ5 and ASCOT. Just quickly, this figure shows the anchor coefficient of the conditional logic model for the 6-dimensional QALAC for the DCTTO data. The estimation results indicate the utility increased with survival duration and decreased according to quality of life impairment levels from higher to lower level for each dimension, where all of the time category is taken as a reference. So utility weights were developed with the estimated coefficient transformed to 0 as being dead and 1 as the full health scale to generate a value set for the calculation of QALY, which is quality of life adjusted years for the QALAC, which can be used for economic evaluation. For Australia, the Australian value set ranges from -0.56 to 1. 1 is the highest possible quality of life, whereas 0.56, which is the big level, the lowest level of quality of life possible. So in conclusion, Qualac has demonstrated strong validity and reliability in home care settings and also strong validity in residential aged care settings. The value sets, that is preference-based score we developed for Qualac, are unique in the focus as they are derived from an older person aged care specific population. Given that Qualac is a valid and reliable instrument, it has got a preference-based scoring algorithm as well. We expect that it has a wider potential applicability in the economic evaluation of new service innovation in aged care, also for quality assessment in any aged care settings. So if you want to use Qualac for health economic evaluation in specific of your any specific project you are undertaking, and you want to use a preference-based score, you can actually get a preference-based score on request. You can actually email me or any of our team members. Both the Qualac and its sister tool, QCSSC, are included in the expanded mandatory quality indicator for residential aged care, and the data collection is going to start from next month. But there's another good news is that both instruments have been piloted to be included in quality indicator program, which is being developed for the home care. So what is the next step? And what are the things we are doing? Also ongoing kind of work around Qualac and QC is that we're going to extend the work into COL population and older people, dementia and cognitive impairment. And also we are trying to unravel the proxy and self-report conundrum, because we actually recommend self-report as much as possible, but self-report is not possible that given that significant number of people, more than 50% have dementia and some level of cognitive impairment while using aged care services. But we just want to understand up to what level of the cognitive impairment people can reliably provide self-reports, and where is the cutoff from where we have to rely on the proxy reports. And we're using mixed method approach to understand this conundrum. We are also collaborating with digital health partners to produce digital versions of Qualac and the QC tool to generate real-time quality of life and quality of care data, which can provide instant feedback for aged care consumers, staff, and providers. We're also looking at potential to extend these tools into other settings where quality of life is the primary outcome. For example, transition care, rehabilitation, restorative care for older people. And we're also looking at the opportunity of expanding this into and extending the work into the other countries internationally, given that there is no very good age care specific and older person specific quality of life and quality of care instruments available. And so given that Qualac and QC are at the moment are the age care specific, older person specific, and best instruments available to measure age care specific person-centered outcomes. So we're looking at extending the work into the UK and also in Canada and other European countries. With that, I'd like to quickly acknowledge the Qualac research team at Flinders University, or other academics and our industry partner who have significantly contributed to the success of this project. And I'd like to invite you all, if you want to know more about this Qualac and the other instrument, please visit us on this website. Thank you for listening, and happy to take any question.
Thanks, Jyoti. That was a really interesting presentation. Congratulations on having that tool going into becoming a quality indicator for residential aged care. That's really fantastic that this is out.
Hopefully they'll make it to home care quality indicator as well.
Yeah, hopefully they do. Look, in the interest of time, let's just go straight to Rachel. Please, can you unshare your screen?
Sure.
And then I'll introduce Rachel, and then we can go on to your presentation. Share my screen. Next up, Rachel. So Rachel is a senior research fellow at Flinders University. With training in health research methodology and economics, Dr. Milte has a growing national and emerging international reputation in innovative health services research. She has proven experience in undertaking high-quality economic evaluations alongside clinical trials and analysis of healthcare expenditure in the context of the Australian health system. So if I'll stop sharing and you can just go delve straight into your presentation, Rachel. Thanks for being with us today.
No worries. Okay, hopefully you can see that. Yep, good go. Okay, so I'm going to be talking a bit more about economic evaluation specifically in aged care. And thanks, Jyoti, for covering a lot of the background to why this is such an important topic and why we're so get so passionate about aged care research. So an overview of my presentation. So I'll be talking a little bit about why we should be undertaking economic evaluation in aged care and what has actually been done in the past. So are people actually undertaking these sorts of evaluations and what have been the results? And I'll finish off with some key considerations to be thought about when undertaking economic evaluation in the sector. So first of all, I'll talk about why economic evaluation is important. So it really comes down to scarcity, and this is the central problem that economists are trying to solve when they're looking at economic evaluations, so resource scarcity. So we understand that there's a lot of budgetary pressure on government budgets from what Jyoti was outlining, in that there's increasing numbers of older people with a decreasing number of people of working age paying taxes to support the system and the government assistance to the system. So decision makers are faced with choices constantly about what to actually provide with the budget that they have. They can't provide everything. So economics and economic evaluation is aiming to try and give them a transparent and comprehensive way to make those decisions. So one of the key concepts in economics that'll come up a little bit later in my presentation is opportunity cost. So this is the value of consequences foregone by choosing to deploy resources in one way compared to another way. So for example, if we make more resources available for joint replacements for older people, that might mean that we're unable to provide aged care services or dementia care services. We might not have enough money left. So it's important that we make the decisions about where to best spend our money, where we're going to get the most health benefits. So that's where economic evaluation comes in. Okay, I might skip through that, but that's just a slide showing the healthcare budget, and the aged care budget is increasing over time, and it can't increase obviously exponentially forever. There's got to be a kind of limits to it. And there's a couple of key drivers to this that Jyoti was pointing out. So one of that is the demographic change, so the larger proportion of older people in society. And we know that older people tend to use more healthcare resources than people of younger ages. Also consumer demands. So we know that people have generally had increasing quality of life or increasing health status. So they're expecting to live into the old age with relatively good health and to be able to perhaps stay at home for a longer time. So their demands and expectations for their life is perhaps increasing as well, and technological innovation. So we know that generally new things, new innovations cost money. So that's also driving this increase in budgetary pressure. So how can we decide how to best spend the government budget? Well, ideally, we'd want it to be a transparent way. We'd want it to be based on evidence. We'd want it to be based on spending the taxpayers' hard-earned dollars in the best possible way to give the best health across the population. And economic evaluation is designed to try and support this. So it's increasingly used to inform decision-making in healthcare. So it's commonly used in things like the pharmaceutical benefit scheme or Medicare benefit schedule to decide what sort of services or drugs are going to be funded through that scheme in Australia, as well as it's used commonly in other countries. However, it's been very rarely used in aged care settings and in social care settings more broadly. So what does it actually look like when we do an economic evaluation? So it's a way of weighing up the costs and outcomes of alternative causes of action. So ideally, economics, often people think about the costs, but you've got to have an idea of what you're actually providing with that money, those costs in terms of the outcomes, to actually make a good decision about how best to spend the money. So it's both costs and outcomes, and it's ideally aiming to answer how much does a new treatment or service cost compared to an old or alternative treatment? Does it work better, the new treatment, and therefore is it worth the money? So it's important to recognise that it may not necessarily save money, a new intervention, but it may provide better outcomes. And if that's, we consider those outcomes to be worthwhile compared to the amount of money we'd have to spend, then it may still be considered cost effective. So there's a couple of, or a range of different types of analyses that we consider under the framework of economic evaluation. So most people would probably be familiar with cost effectiveness analysis, which is looking at, these different types of economic evaluation all measure costs in some way, but they differ in how they treat the outcomes that are being measured. So in terms of talking about, I'll move on to some actual examples of economic evaluation in a minute, but just thinking about the sorts of costs that you'd collect in an economic evaluation. Just to point out, a lot of people would think about the healthcare sector, obviously, so the costs associated with hospitalisation or GP use or pharmaceuticals, but you can also consider other costs as well more broadly. So this might be costs to other parts of the public sector, such as the aged care sector, a big one, but it might be the education sector or the workforce, for example. You might consider costs to the patient themselves, where they're having out-of-pocket costs. So again, that's of relevance to the aged care sector. And ideally, you'd want to consider a societal perspective. So that's where you'd be considering a range of all of these perspectives. So all of these different costs to all of these different sectors to get a holistic idea of the cost and value of a particular new intervention. So this is where we know that, for example, reducing staffing in aged care might result in a reduction in costs for aged care, but you might have a flow-on effect in terms of people going into hospital or emergency department from aged care more frequently. So something that might seem as though it's saving money may not actually save money when you look at that broad societal perspective. And when we're thinking about economic evaluation, we can consider the benefits in a range of ways. So you could consider, for example, natural units. So they'd be things like clinical outcomes, like blood pressure, might be reduction in pressure sores, those sort of things that would be familiar from a clinical perspective. A really big, important outcome measure for our work in economic evaluation at Flinders is quality of life. So we're often considering that as, I guess, the ultimate aim of the aged care system as well as the healthcare system. It's often to improve people's quality of life. So we're interested in that as an outcome measure as well. And you can consider savings or monetary units as well. So that's a brief crash course or overview of economic evaluation, just to give a bit of context to the next slides that I'll be presenting. So I'll move on now to discussing economic evaluations that have been conducted in aged care previously, and answering the question of whether these evaluations have been undertaken and what they've actually shown when they have been undertaken. So if you're interested in this topic, I would refer you to a couple of systematic reviews that have been done by people in our team. So Tiffany Easton was a PhD student of ours a couple of years ago, and also by Norma Balimu as well, who was a PhD student of Billy's as well. And so these students have looked at systematic reviews of the economic evaluations in residential aged care in the case of Tiffany, and in community aged care for Norma. So I'd recommend you have a look at these reviews if you're interested in what's been done in this area before. But I'll talk a little bit about what Tiffany Easton's review actually found in residential aged care. So Tiffany, she actually published 2 reviews. She was focusing on workforce and care processes in residential aged care in one, and she also published a second review, which was more focusing on organisational and environmental characteristics of the facility. So this first one on workforce and care processes was looking at ways or improvements to the staffing, perhaps, or the way of providing care in residential aged care. And what she actually found was that there was quite a limited number of studies in this area. So she screened over 23,000 studies for inclusion, and she only identified 19 studies worldwide which had included an economic evaluation of a workforce or care process intervention. Of those, only 7 included a combination of cost and outcome measures. So that's where they presented the costs associated with an intervention, along with some kind of analysis of the outcomes that were achieved. The majority, 12, included a look at the costs only, which is useful, but as we were mentioning previously, that only really tells you part of the story. It doesn't tell you, I guess, it tells you whether you can save money with this intervention, but doesn't give you an idea or how much this intervention would cost to run, but it doesn't give you an idea of the value that you'd actually get provided with that intervention. So of the studies that she's identified, I've just put a snapshot of a couple of the studies that were found to have a benefit in her review. So she found that, for example, providing additional registered nurse direct care time, which is a very topical topic at the moment in the aged care sector, provided net societal benefits of $3,000 per resident per year. So she found that that was provided a benefit. There was another study which was by Grabowski, which looked at providing an out-of-hours doctor telehealth consultation service to residential aged care versus a regular on-call doctor. And that identified that there was $12,000 savings per facility per year via savings on hospitalisation. So they're actually able to divert residents from going into hospital, which resulted in a savings for the facilities who'd implemented that program. There's another study in Canada, which increased physiotherapist and OT staffing within the facilities and showed that they were able to improve and limit the functional decline that the participants were experiencing, the residents were experiencing, which reduced the care load for those participants and resulted in a saving for the facilities. And a program in Canada, which was looking at implementation of an advanced directive program, so helping people make decisions about how they want to be supported in their end of life stages, showed lower hospitalizations for those who received that intervention, which helped to lower costs as well. And we also know that most people want to stay at home or in their facility. They don't want to go to hospital at their end of life stage, depending on the circumstances. But so there would be a benefit for that program from that perspective. So looking at the review Tiffany did focusing on infrastructure and organisational interventions. So these were interventions that might be looking at the organisational characteristics of the different facilities. So it might be that they were operating for-profit versus not-for-profit, had a particular location or size, or it could be modifications to the environmental characteristics, such as, say, home-like facilities compared to large-scale residential care facilities. And she identified 14 studies that were focusing on these aspects, and all of these analysed only the costs. So none of them included comprehensive cost and outcome combination framework as part of their analysis. And of this as well, only 2 studies included people living with dementia, which is really astonishing given that over half of the people in residential care actually have a diagnosis of dementia. I'll just head along a bit in the interest of time, because I want to pass over to Billy. But just to note as well that we've actually undertaken a study called the Inspired Study, which was looking at the costs and outcomes of different models of residential aged care in Australia, and was one of the first studies of its kind. This was published in around 2018, and we were actually able to demonstrate a cost effectiveness of the small domestic or home-like models of residential aged care compared with standard larger scale residential care facilities that are more traditional. And we were able to demonstrate not only a saving for the small domestic models in terms of reduced costs of medical intervention, as well as a difference in the quality of life of the residents that they experience with that small domestic care. So that has been published. So just to highlight that these interventions can be considered cost effective when you're actually considering those outcomes as well as the broader costs. So I'll finish off with just a couple of key slides about considerations that we think of when we're undertaking economic evaluation in aged care, or some particularly, I guess, interesting areas for future research for anyone out there listening who's interested in this topic. So one thing is actual informal carers. So we know that informal care is an extremely large part of the aged care sector in Australia, or the care provided for older people, but it's often underreported and underrepresented. So informal carers provide 32 hours of care per week in Australia on average. So that's really, almost a full-time job. That's huge. So when we're considering in our aged care economic evaluations, it's important to think about the costs to the actual informal carer, the opportunity costs. So this person might have come out of the workforce to actually provide this informal care, as well as what we call spillover effects. So this is where the benefits to the carers may actually be incorporating the carers may be experiencing benefits for the intervention as well as the older person themselves. Another key consideration, as Jyoti was discussing, is the actual measure of benefit. So which quality of life instrument are we using? Who should value those benefits, which I think Billy might discuss more in his presentation as well. And that's a really important consideration in terms of getting your outcome measure right. I might slip through and just talk in brief as well. Another key important consideration is actually how to combine how you're looking at self-report versus proxy report, and how you combine those into your economic evaluation as well, because proxies can report quite differently to people having self-report as well. And so in summary, there's not been a lot of economic evaluation in aged care, but it is changing, and there's a really big potential for impact in this area. So I'd encourage people to be doing more of this type of work. And I think I'll hand over to Jyoti probably, to Billy, sorry, mate.
Thanks, Rachel. That was really fascinating. Interesting to see how few studies look at both cost versus outcome, in the literature, although you are saying it is changing. It'd be great if you can send me the links to those systematic reviews, so we could maybe share them to our audience. I'll share my screen now to just finally introduce Billingsley, or Billy, as your colleagues call you. Billingsley Kaambwa is an associate professor in health economics and head of health economics within the College of Medicine and Public Health at Flinders Uni. He's a member of the Australian Medical Services Advisory Committee panel for health technology assessment services. And he has extensive experience in research and teaching. His main research interests are in the application of econometric and statistical techniques in economic evaluation, decision analytic modeling, and economic evaluation of new and existing healthcare technologies. So I'll stop sharing and hand over to you, Billy, to finish off today's session, really interesting session on healthcare, aged care, economic evaluations.
Right. Can I just check that you can see my slides?
Yes, perfect.
Okay, thank you. Thanks, Jyoti and Rachel. I think you have laid the foundation in for me. I have 11 minutes. I'll try and finish off my presentation in that time. And so thank you to the Health Translation SA for this privilege, to come and just present my work. What's happening with my slides? Okay. All right, so the title of my presentation is Establishing the General Public's Value of Publicly Funded Aged Care Services. And like Rachel did mention, a key problem faced by the discipline of economics, be it transport economics, financial economics, or indeed health economics, is that there are limited resources or finite resources that have to be spread over a range of unlimited human wants and needs. And this does indeed put pressure on budgets. And one of the sources of budgeting pressures, especially in Australia, is the aged care sector. This is because Australia, like many other developed and developing countries, is an aging population. And so it can also be argued that when you are looking at components of health technology assessment, the process when it pertains to aged care includes understanding or determining the value that the general public places on aged care services. So what I'll share with you in the next few slides is part of the work that we did for the Royal Commission into Aged Care Quality and Safety. This is trying to determine what value the general public places on aged care services. And this is according to the quality rating of these services, as well as the setting where these services are provided. So why focus on the general public instead of consumers, for instance? This is because the majority of these services are funded by the federal government using taxpayer contributions from the general public. And so it's only right that they be asked to ascertain or determine what value they place on these services that they fund through their taxes. And I guess, when we look at the total spending in terms of government contribution to aged care sector, you can see that the investment in aged care sector, I don't know how well you can see that slide on your screen, but it's increased from 13.3 million in 2012 and projected to increase to 34.7 billion in 2025-26. So this is an increase of about 161%, which is quite a big increase. And so when we are looking at this question, really, the research question is a simple one. What value does the Australian general public place on aged care services? And then we also wanted to understand whether this value differed by important subgroups, some of which are shown there on your screen. And so to do this, we use the willingness to pay approach. Many of you might be familiar with that, but it's part of the broader contingent valuation framework. And some argue actually that this is one way of facilitating value-based pricing, which is a strategy of setting prices based on the consumer's perceived value of a product or service. And so this is what we used in our analysis. And so really this approach involved asking questions in 3 steps. So we wanted to estimate what a consumer, in this case, what the general public might be prepared to pay for aged care services. And so we asked this in 3 steps. In the first one, we wanted to find out whether or not the individual was willing to pay a contribution to aged care services. So that was the first question that we asked. And if they said yes, then what was the value of that core contribution? And so this ranged from $75 to $450 per week. That's for home care. And it ranged from $400 to $1,400 for residential care. And these values reflected the market prices at the time that we did this survey. Now, this question was asked in a payment scale, and the maximum was $450 for home care, and the maximum was $1,400 for residential care. But we also gave an opportunity in the third question, for people to put a dollar amount if they thought that they were prepared to pay more than the maximum amount that was shown on the payment scale. But from a methodological point of view, we're also interested in 2 questions and 2 potential biases. The first one was what we termed price depression bias, where respondents feel that when they ask this question, the research is somewhat supportive of policies that are aimed at removing state funding in favor of individuals paying for these services themselves. So they might then undervalue the services because they feel that they don't want the state to take away these functions, these services from them, and them to start paying for them. And the second bias that we looked at was that of the budget constraint bias. And so this is when respondents consider an intervention in complete isolation. And so they are then willing to pay sums of money far in excess of what they would be willing to pay if they were asked to consider the same intervention, but in relation to a range of other interventions. And so those are the 2 biases that we wanted to explore from a methodological perspective. In terms of analysis, so we did bivariate analysis, and we also did a 2-part regression analysis. So the sample size was 10,000, so slightly over 10,000 individuals that responded, aged 18 to 90. And what we found was that depending on the type and setting of aged care services, between 45 and 80% of the respondents were willing to pay to access these services in the future. And we also found that a higher proportion of respondents were willing to make a core contribution to access home care as opposed to residential care. So they were willing to, they wanted to stay at home rather than going to a facility. We'll just quickly share the actual weekly willingness to pay figures. And our analysis showed that the willingness to pay figures for home care were higher by about up to 500% than what the government paid at the time, which was $30 for home care. And so one could argue that there was some budget constraint bias going on there. In terms of residential care, our analysis showed that the figures were lower by up to 80% than what the government paid at the time, which was $502. And so here one could argue that there was some price depression bias going on. The other thing that we did was to just look at which subgroups were willing to pay more than the others. And these are shown on the screen. So for instance, males were on average willing to pay between $11 and $32, compare more than females. And taxpayers, for instance, were willing to pay between $10 and $45 more than non-taxpayers, and so on and so forth. But what I just want to highlight here is the fact that the biggest drivers of willingness to pay seem to have been those individuals that had a family member receiving home or residential care at the time of the service, or that experience of having received them, those services drove them to prefer a higher willingness to pay values. Of course, income level, that was unsurprising. but also residents in the ACT and the other eastern states, were willing to pay more. So there were no surprises here. And so with 1 minute to go, these were the conclusions, that we came to. So aged care was important, gauging by the number of people that were willing to pay for aged care. Our research demonstrated the significance of aged care to the general public, but also what it showed was that the quality in aged care is valued. The quality, is valued highly, and so people were willing to pay more for higher quality, and respondents were willing to pay core contributions to finance their access to home and residential care in line with their ability to pay as well. And so just acknowledging my co-authors on that, and also the Royal Commission into aged care and quality that paid for this work or funded this work. And for those that would want to read more on that, this article appeared in Social Science and Medicine in 2021. Thank you.
Thanks, Billy. That was really fascinating. Such an interesting study, and interesting to see what are the categories or the demographics of people who are willing to pay more. Looking at family members of people who've gone through the aged care, they obviously probably have a firsthand view of what are the services that they received in aged care, so they might be more willing to pay, knowing what the services are. Just the results were very interesting, and I'd love to share that paper that you just presented. So if you don't mind sending me the link, I can share it to our audience members.
No worries.
Are there any questions from the audience, knowing that we've reached the end of our session, but just curious to see if anyone has a comment or a question for our presenters today. No? Well, in that case, I will just tell you about next week's webinar, which is going to be on Thursday again, between 12 and 1. And we're going to be looking at health economic evaluations in the context of looking at research impact. So what impact do research projects have, and how health economic evaluations come into that context. I'd like to thank our three speakers today. It was such a good, really good in tandem presentations. They really flowed well one after the other, and I can see that you work together, and the work that you're producing is very valuable. And I'd just like to thank you once again for sharing your work with us and our audience. So we'll see you next week on the 30th of March for webinar number 4, which is going to be the last one in our series on health economics. So thank you very much again, and we'll see you next week. Thanks, everyone.